Hi, everybody. Today we're going to carry on talking about fractures or radiology series that we've been having. So we've moved on from the hip, and now we're going to talk about femur fractures. It is a little bit long, but I'm going to try and get through it as quickly as possible because I think most of you should recognize a femur fracture. And we're just going to talk about the different types that you get and the things that you need to worry about. The first thing that we're going to talk about is just subtrochanteric fractures. So as we had mentioned, once you've got your greater and lesser trochanter, then you're talking about just that area just below there. Now, this one here is often associated in the elderly with low impact, low energy impacts. And they can present with quite significant shortening of the limb and extremely painful. But in a younger person, if you get this, always look for additional injuries. Generally, you tend to get acetabular injuries as well, and you tend to get pelvic injuries associated with that. But it's much more common in the elderly. You don't really find it that much in our younger cohort of patients, but it's more common in elderly patients. Very osteopenic bone, associated with a lot of other factors as well. Now, this is something that I often found people troubling or having trouble with is what do you do when the patient's got an implant? So this is how you assess periprosthetic fractures or fractures around the prosthesis. So here we have a hip replacement there. So the most important thing is get the entire prosthesis in the X-ray. Ideally you want to get the entire femur as well, even though I've just shortened it for this particular one. So here you can see the fracture quite clearly. So you can see our implant, you can see the bone surrounding the implant, and you can see that the rest of it has actually separated. Now, of course, if there was callus over here, then it wouldn't be a fracture. But these are quite straightforward as well. The most important thing is that these patients need to go back to theater to have this repaired. I'm not an orthopedic surgeon myself, so I know they have a different way of looking at this exactly and how they decide who's going to get a new prosthesis and who's just going to get fixation. But trying to get the entire femur in the X-ray helps quite a bit as well. Now, this is something that we don't see that much in with the public hospitals, not because we just that a lot of our patients are not on biphosphonates. But if you're working in the private sector, you find a lot of patients are on biphosphonates, and this is a little bit more common. Now, the thing with these fractures, it's similar to a stress fracture in terms of the fact that you're not really getting huge fracture lines. You're actually just getting thickening of this cortex where you're getting callus formation. And it's a result of decreased bone turnover, increased bone fragility. You can sometimes have multiple fractures as well. So it's generally amongst patients who have this, in the subtrochanteric region. And it's something that we call an atypical stress fracture. And it's typical laterally, as we can see, but very difficult to make out. You have to really look for it. And you really have to be sure that you have taken a good history and you know exactly what your patient is on so that you know. So how they present exactly as they've put it here, they present with mid-thigh pain. You just have to stop the biphosphonates, just alter the activities, and always consider this if the patient is on biphosphonate therapy. So in some centers they do take them further and do MRIs to look for the extent of the fractures and things like that. But there's not really much you can do in terms of theater and things like that. It's mainly stopping the medication and trying to get the patient to change their activities. So these are the most common femur fractures that we see in our emergency departments. So they're normally due to high energy impacts. You must look for associated injuries, specifically, your neurovascular injuries as well. Young patients, it's always a result of high energy. We all heard the common saying that our femur is stronger than an equivalent steel rod, and it's true. If you've ever had the chance to work on these in theater, the femur is extremely strong, and it's extremely difficult to actually fracture it. If you look at the lattice work within it, it's an extremely stable structure. So it takes quite a bit of energy to actually fracture it. However, with the elderly, low energy impacts can also cause it, and even a same level fall. So that means, just a small fall can also, cause quite significant fractures in the elderly. Now, they are associated with significant blood loss, sometimes up to 4 units. And with these patients, especially once they start looking a bit pale, you've also got to look for fat embolism as well. But we'll get through to that in a little while. And profuse bleeding can lead to hypotension. So if you have a patient who's hypotensive with a femur fracture, always consider that the bleeding may be coming from here. And a lot of these patients do need to be transfused and do need emergency blood and things like that. Now, most of the time, if you reduce it with skin traction, you're going to decrease the amount of bleeding from there. And if any of you have had the chance to put in an intraosseous line into a femur, you'll actually notice how vascular it is, and that tells you why we need to be worried as well. And I mean, it's one of the reasons why we use intraosseous lines, because the intraosseous space is so well connected to the vascular space as well. So the treatment of this is surgical, whether it be nailing, whether it be replacements, whatever it may be, but nailing being the most common. And then you have, of course, your ballistic fractures. So these are high velocity projectiles. It doesn't matter where it came from, shotgun, handheld, semi-automatic, it doesn't really make a difference. These are quite dangerous, So you normally have an entry and an exit wound. It's important to note where the entry is and where the exit is as well. And of course, if there's no exit as well, it's also very important to note the side that the patient is injured on. So generally on the medial end, let me just get our drawings over here. So remember, sorry, let me get this here. So remember that you've got your artery running just there as well, just try and get this, let's try and get it. So you remember you've got your femoral artery running on this side. You've got your femoral vein running over there. All right, just next to that. And then next to that as well, now you've got your femoral nerve that's also running on that. So that's that massive neurovascular bundle that's running over there. And then, of course, you've got your deep artery. My apologies for that. I am recording this and then you've got your deep artery coming out from there and your superficial. So, you've got a lot of neurovascular or potential neurovascular injury from that. So your focus should be on resuscitation and ensuring adequate distal blood flow, which is 100% correct. So you want to make sure that there are pulses distally to where you are, to where the gunshot is. The treatment is surgical. These patients do have to go into theater. And sometimes they do delay, they do proper vascular imaging, but I must be honest, in most of the cases where we've had an obvious arterial or AV, let's just say arteriovenous injury, it's very rare that we'll wait for emergency CTs or CT angios and things like that. The principle of let me just get this here again, sorry. So the principle of what we're trying to do with any of these injuries. So let's just say we've got our artery that's running around over there, and we've got an injury that's, we've got a transection here. The main thing is to actually is to try and get proximal control. So what you're aiming for is you're aiming to cut off the blood flow from there some way, so you've normally got to incise within the femoral canal, somewhere over there, and that's not an artery, it's just to indicate where we do the exploration from. And then when you go down, you look for the of course this is after you had opened up here, you would then try and obtain distal proximal control and then work on the distal ends. And of course for a vein it's the opposite way around. So these can be quite dangerous, and they can bleed very significantly. And what happens is that if you leave it long enough, eventually you just get, either the patient is going to bleed out, or you're going to get, a devascularization of the distal areas, and you may even have to amputate and things like that. So, these are one of those patients that you really need to work quickly. Okay. Oh, sorry. I need to get out of all those drawings. Didn't realize it would stay on. Okay, now I get towards the bottom of the femur. So supracondylar fractures as well, quite common, relatively common, let's put it that way. So it's also high energy impact in younger people and low energy impacts in elderly patients. So these patients will have a very obvious knee deformity, and there'll be a lot of pain. These patients, they cannot put any weight whatsoever on that joint. They normally come in splintered, or you'll find a lot of people carrying them in trying to stabilize the limb. It's an extremely, extremely painful fracture. The problem is that it can mimic a dislocation, a knee dislocation. So what you've got to do is just sort of palpate around that area, and you'll normally notice that it's not a dislocation of the knee. You can actually feel the fracture. And there's normally quite a bit of bone crepitus as well. They're also quite prone to bleeding as well. And these are also those that, are potentially neurovascularly important. So I just want to show you here. So you've got your femoral artery that comes just around the back over there. And then just in this area, this is where you get the trifurcation. So you get your trifurcation into your posterior tibial, your anterior tibial, and your what was the other one? Okay, you guys can remind me on what it is, but so you get the trifurcation. So anything in this area can easily lead to a decrease in pulses. So what you've got to do is you've got to check all three pulses. So you've got to check your dorsalis pedis, you've got to check your anterior tibial pulse, and you've got to check your posterior tibial pulse as well, right? To make sure that all of them are there. Otherwise, you're going to miss something. Because any one of those arteries being affected is going to affect the compartment of that calf and foot, and that could lead to problems later on down the line. Okay, so these patients also go into theater quite all the time, and as I put, your vascular injuries do occur due to the proximity of the femoral artery. And now we get onto something a bit interesting, pathological fractures. Now, for those of you who want to read through all of this, it's quite interesting. I've put it all over there. I'm not going to go through the whole thing. It's quite a bit to read out. But let's just say that pathological fractures are quite common. Pathological fractures are things that we need to consider. Pathological fractures likely don't occur in isolation. And I say that there's normally a history that comes along with it that would show you that there's evidence of, a neoplasm somewhere around that area. And very often the surrounding bones are also involved. And, the patients, especially when they get to this stage, if this is a primary presentation, the patient's already at a stage where the neoplasm's taken quite a bit of a toll on their body. So they would have evidence of paraneoplastic syndrome. They'll have paraneoplastic symptoms. They have neoplastic symptoms, and have so much that's going on. So it's very rare for these things to just occur. Now, these are just some ways that you can have a look at that. So on PET scans, they show up quite hot. So that's one way that they sometimes use to differentiate them, especially in cases where they're not 100% sure. But it's not very common in our setting, but it is done. This is just an intratrochanteric pathological fracture. And if you look here at this, you can actually see the mottled appearance of the bone. I'm not sure if it will show up on but we can actually see a little bit of it on the pelvis there. Besides the recess spot, there's a little mottling effect going on over there. Here you can see the mottling a lot more. So it shows you how bad the metastases were, for the patient to be able to develop such a fracture. And then this is just this is especially in complete knee replacements, where you see this type of distal periprosthetic fractures that occur. Now again, it's something you can read through on the side if you want. but it's not that common, luckily, but it does occur, so it's more common in patients with osteoporosis, which is unfortunately or fortunately not the biggest cohort of patients that normally go in for these procedures, but it is a possibility. So if there is a history of osteoporosis, always think of this as well. Fractures themselves are quite easy to make out. It's not really a problem. And the most important thing, especially in the emergency department, is to get full length x-rays. The reason being, once the surgeon is planning for theater, it just saves a bit of time for them as well. Now, in femur fractures, one of the things that we need to worry about is fat embolism, and this is something that's often overlooked. Now, it is quite easy to recognize. It's not common when we compare it to the number of fractures that we see. I don't have exact figures, but just going anecdotally over my career, I would say for every 30 fractures, femur fractures that I see, let's see one fat embolism from there. So, that's just anecdotally. I haven't really looked up worldwide stats and that. But the reason for that being, it's much more common in young adults with what I like to call meaty bones, which means that bones that are fresh, bones that have a lot of fat inside them as compared to the elderly, where they tend to have drier bone, less fat that could embolize. But it can happen at any age, but the incidence goes down at the extreme of age. So what happens is you get a long bone fracture, and then you get microvascular obstruction, all right? And then, as they say here, your endothelial injuries and inflammatory cascade, and then they get adult respiratory distress syndrome. So that's the first thing that happens. And the second thing is arterial hypoxemia, so encephalopathy and focal neurological deficit. So this patient becomes confused. This patient can't breathe, and then the patient starts getting petechia. Now, the petechia in this case are due to vascular stasis, microinfarction, also your endothelial damage, all right, that takes place, and it ruptures those thin wall capillaries, and then you get DIC, thrombocytopenia, and anemia, and these are due to the factors stated here, all right. It's quite an interesting pathophysiology when you go through it. But the most important thing to remember is you have a patient with a femur fracture or long bone fracture, is confused, can't breathe, you look for petechia and you look for bleeding, and you've got fat embolism. So this is just breaking it down. So fat embolism syndrome, it is a diagnosis of exclusion, but you have confusion, agitation, particular rash can occur as well. But the most common place to see the petechia is in the eye. So it's the first thing that you kind of look for when your patient is struggling to breathe. The first thing that you do is intubate this patient. Don't worry, your saturation can be 100%. It doesn't make a difference. You make sure that you intubate this patient. There's not much that you can do in an emergency department setting to actually offset most of the other problems that are occurring. So, for example, the cytokine, the whole inflammatory cascade, it's very difficult to get that under control in an emergency department. Even though we can, there are things that we can do, but for the majority of you working in an emergency department, it will not be something that you can do in that immediate setting. And again, there's not much that you can do about the encephalopathy. The most that you can do is try and get as much oxygen into this patient as possible, and then, like I say, get them into the ICU, and then let the specialist take over from there. It's a long road for these patients once they do get it, depending on the institution, I would say, that they find themselves in. The outcomes vary wildly. But if you catch it early enough, most of these patients will be okay. So, just a little joke to end up. So, we've covered the femur. We'll go on to the knee, hopefully in another week or two. Generally, the recognition of the fracture is quite easy. It's not that anybody should struggle to be able to see a femur fracture. I haven't talked specifically about the pediatric fractures because that's I think a separate topic all on its own. But I think the most important things to take away from this is that young people, it takes a lot of energy to break the femur. Older people, it doesn't take as much. Younger people will tend to bleed more, but older people can. When I say younger, I'm talking about young adult as compared to the extremes of age. The possibility of fat embolism syndrome is much higher. So it's something that you always got to keep in mind. So be ready to intubate these patients. Be ready to transfuse these patients. And don't forget, if there's a ballistic injury, And in our case, we've even had stab injuries, penetrating injuries like that, that have also caused quite severe injury around that area, although not fracture. But it's the same principle that you use, you know. So just be careful with these. Don't get caught out. Don't just say, oh, it's a fracture, like a wrist fracture or something, and leave the patient one side. Keep these things in mind. And like I said, I hope you guys enjoyed it, and try and have another one next week. Okay, keep well. Bye.